Luana. Thank you guys so much. Have a good time.
Hello to our guests from Baltimore and around the world. I am Dr. Jason Noel, Associate Professor at the University of Maryland School of Pharmacy and Deputy Director of the Placebo Beyond Opinion Center, the PBO Center. On behalf of the PBO Center, we'd like to welcome you to the first session of the 2024-2025 Guest Lecture Hybrid Series. Today's session will be a panel discussion entitled Psychedelics in Pain Management, Exploring Therapeutic Potential, Pharmacology, and Clinical Considerations. PBO is a research center committed to moving beyond mere opinions or assumptions about the placebo effect and delving into rigorous scientific investigation. Through collaborative research and educational initiatives such as today's presentation, we aim to advance knowledge and application of placebo, nocebo, and expectation effects. To learn more about our center, please visit our website. We'll put a link in the chat. The website is available through the School of Nursing at University of Maryland. You could also follow us on LinkedIn. Today's webinar is being recorded. A link to the recorded presentation will be available within a few days on the events page of the PBO website. We welcome you to revisit the content yourself and to share it with colleagues once it's posted and available. Each panelist will deliver brief remarks. We invite your comments and questions for the panelists. Please look at the Q&A chat box on the Zoom app on your screen. And if you have a question for the speakers at any point, just type it into to that chat box and we will pose it to our speakers either after their individual talk or hold it for the Q&A discussion portion at the end of the event. So we are very pleased today to have three esteemed scholars on the pharmacology of psychedelic agents and their applications in pain management and mood disorders. I will introduce our first panelist is Dr. Andy Coop. He's a colleague of mine here at the University of Maryland School of Pharmacy. He's a professor of pharmaceutical sciences and the Associate Dean of Graduate Programs. He received his PhD from the University of Bristol in Chemistry of Drugs of Abuse, followed by a Fogarty postdoctoral fellowship at the National Institutes of Health. As a faculty, his research focuses on the design and synthesis of novel opioids, as well as elucidating the influence of the cholinergic system on major depression, with funding received by NIMH, NIDA, National Cancer Institute, and other state and federal sources. Dr. Coop has been appointed as the chair of Maryland's Task Force on the Responsible Use of Natural Psychedelic Substances, where he will shape policy around the education and safety, regulated treatment, and production of natural psychedelic substances. Turn it over to Luana, who will introduce our other speakers.
We will continue today with Professor Maurizio Fava, the chair of the Mass General Brigham Academic Medical Center's Department of Psychiatry at Massachusetts General Hospital, and the Slater Family Professor of Psychiatry at Harvard Medical School. Dr. Fava obtained his medical degree from University of Padua School of Medicine, where he completed residency training in endocrinology. Afterwards, he moved to the States to complete a training in psychiatry at Mass General. He founded the Hospital Depression Clinic and Research Program, then went on to establish the Mass General Psychiatry Clinical Trials Network and Institute, the first academic CRO specialized in planning and coordination of multi-center clinical trials in psychiatry, where he continues to serve as the executive director. Dr. Fava's work has been supported by over 95 million in funding from NMH and other sources, including his work as principal investigator on STAR-D, the largest research study ever conducted in depression. Thank you for being with us, Professor Fava. And finally, another dear colleague and friend of mine, the 30th panelist is Dr. Patrick Finnan, the Harold Carroll Professor of Anesthesiology at University of Virginia School of Medicine. His background is in psychology, with emphasis on the cognitive, behavioral, and affective mechanisms and treatments for chronic pain. He obtained his PhD in clinical psychology at Arizona State University. He continues training with a clinical internship at the VA Medical Center, then did a postdoctoral fellowship at Johns Hopkins School of Medicine. His research program at the University of Virginia is supported through numerous NIH grants, where his group performs studies using both laboratory and psychotherapeutic intervention to prove mechanism underlying chronic pain and pain therapeutics. A major focus of his research to date has centered on measurement and analysis of dynamic measures of pain and emotion captured during daily life. We are very pleased to launch this webinar with Professor Coop. Thank you.
Thank you very much for inviting me here today. And I am honored. I'm going to share some slides in a second, but I am honored to talk with such esteemed colleagues. And one of the things to bear in mind and just take home from this is that the three of us talking today are from such varied backgrounds, and we need all of us from the different varied backgrounds to help move the whole area of psychedelics forward, especially as the focus today on their use in pain. In fact, one of the things, and hope several other people watching are already part of our multidisciplinary perspectives on the science and practice of psychedelic therapies, an interprofessional education, continuing education program we also host out of the University of Maryland, Baltimore. But today I'm here to start with the basic science. I'm not here to talk about the clinical aspects. My two colleagues can do a far better job with that than me. I wanted to give just a little bit about the science of, where am I? There I am. Can we see my slides? Let me stop sharing. Okay, I've got it open in a strange way, but that's fine. I want to talk briefly about the pharmacology of psychedelic agents. And I effectively, on my first slide, have the take-home message that I will spend the next 5 or 6 minutes talking about, is that we tend to talk about all psychedelics together, but each is a different drug with its own pharmacology. Yes, we talk about 2A, but each are different, because in addition to interacting with what I call serotonin 5-HT2A receptors, and by the end of my talk, we will understand what that means. Not only do our range of psychedelics actually interact with this specific biological target, each interacts with a range of additional targets that are unique to each psychedelic agent. What that means is that, yes, the majority of the effects through 2A are dominant, but it also means that each drug is going to be a different drug in its own right, which means that it's going to have different effects. So we cannot simply lump all together to say that they're all going to behave the same. In addition, I'll talk a little bit about today that not only do they have immediate acute effects at the receptor of target, one of the major mechanisms of action of psychedelics is actually changes to the neurons within the brain, what we call metaplasticity, growth of new neurons, growth of new dendrites, new connections between the brain. So this means that the metaplasticity, plus the fact that all these agents interact with different molecular targets, means that each one is a very complicated system. And the one thing I do want to then finish on is the legal aspects of psychedelics seem to be following a somewhat similar pattern to cannabis at the state-by-state level. And they will be another tool in the arsenal for the benefit of patients, especially here today talking about pain. As such, advocacy and education, both of the population and of healthcare professionals, is critical. So let me take you through a little bit about the pharmacology of psychedelics. What we need to talk about is within the brain in terms of neurons, which are brain cells. Electrical signals get sent down the brain cells. But what happens is, how does one neuron communicate with another? Because the signal goes down, but how does one communicate with another so that the message continues down into another neuron? Well, this is where we come up with the term called neurotransmitters. And at the end of a neuron, neurotransmitters are released. Now, neurotransmitters, I'm sure you've all seen the ads on television for antidepressant SSRI medications, get released. In this case, we'd be looking at serotonin, which is one of the neurotransmitters. They are individual molecules that move across the gap between the neurons in the synapse and interact with a target shown here on the right-hand side called postsynaptic. There are presynaptic, but let's not get into that. There are postsynaptic receptors, they are called targets, which activation of those receptors continue the message in the second neuron. So this is actually how and where psychedelics exert the main effects. I mentioned one of the neurotransmitters, and there are many, is serotonin. And what you will see is that when we're talking about serotonin being one of these neurotransmitters, we often talk about 5-HT. Where does 5-HT come from? Why is it called 5-HT? Well, that's simply, I'm showing the chemistry here, is that serotonin chemically is called 5-hydroxytryptamine. That is where the 5-HT comes from. So when we say 5-HT, we simply mean serotonin. The numbering system is just how we chemists name where that OH is, the hydroxy. So serotonin, or 5-HT, is these little green balls as shown here that transverse across the synapse and send the message. But those receptors, what we're showing here postsynaptically, the little receptors that the red arrows are pointing at, they are receptors. So serotonin binds, interacts with these receptors and activates them. But how many are there? Are they all the same? Well, actually not. We know there are at least 14 different types of receptors for serotonin, each of them having their own effects. Now you see how complicated this is. They all have different names, but the receptor, the one out of the 14 that seems to have the main effects, the main target for what we would call the traditional psychedelic actions, is what we call the 5-HT2A. There are whole names of them, 5-HT1 to 5-HT7, 2B, 2C, etc. But it's just names of these 14 different biological targets. One of them, 5-HT2A, is the target for the majority of psychedelic agents, the traditional psychedelics agents, which is why we often talk about 2A. Now you understand why we say 2A. It's activation of the receptors of 5-HT2A. So if we look at some of our classical 2A agents, these are agents that actually act like serotonin, bind to 5-HT2A receptors and activate those receptors. Here are 4 traditional classical 2A agents: DMT, dimethyltryptamine, LSD, psilocybin, and mescaline. All of these agents do indeed interact with and activate 5-HT2A receptors. So this should be the same, but they're not. We're not even going to get into what we call pharmacokinetics here, which is how rapidly they act. What we're getting here is to what else do they interact with? And I wanted to tell you that DMT, dimethyltryptamine, not only does it interact with 5-HT2A receptors, it interacts with a range of other serotonin receptors, 1A, 2C, 2B, a range of other serotonin receptors. But not only serotonin receptors, they also interact with what we call the alpha adrenergic system, another system. But it also gets even more complicated because if we go back, the release of serotonin from the presynaptic to travel across to the postsynaptic receptors, DMT actually causes an increase in the release of serotonin as well. So it interacts with the receptors. It causes an increase in serotonin, which then interacts with all 14 serotonin receptors. You see how complicated this system gets, but it also interacts with others. Let's just quickly go through the others. LSD, again, 2A, but also interacts with dopamine receptors as well as alpha adrenergics. See, the dopamine influence is going to make it different to DMT. Psilocybin from mushrooms interacts with a range of different serotonin receptors, and importantly, unlike LSD, doesn't have any dopamine effects, another neurotransmitter. And mescaline, mostly traditionally from the peyote cactus, interacts with another range of serotonin receptors. So they're all classical 2As, but they will all have other effects. We need to look at each of these drugs as if they are independent drugs, just like we would with other. So here we go, talking about the other sites of action. I got ahead of myself. I had a slide here just talking about them. But then again, we need to think about the longer term effects, the metaplasticity. The mechanisms behind why these drugs lead to the growth and new connections and increase of complexity of neurons is not absolutely confirmed. Is it through the 2A receptor? Or is it because they tend to interact with this additional target called brain-derived neurotrophic factor, BDNF? There's a few slides here to show how this actually causes structural changes within the neurons and the connections within the brain. But then we also have other drugs that are lumped in with psychedelics, such as ketamine. Ketamine interacts with generally not 2A. This is MDMA, which is N-methyl D-aspartate, a completely different target. MDMA, ecstasy, this again a different target. This tends to be a releaser of all neurotransmitters. And there are other non-2A psychedelics, such as salvinorin. There are so many different psychedelics. The 2As are different, similar, very similar, but different. But then the ones that don't work through 2A, such as ketamine and MDMA, are very, very different. And I hope I've explained that to you today in this very short talk. Just quickly about advocacy, this is a major part of the task force I'm on. Education of all is critical. States do appear to be following a similar path to cannabis, so we need to ensure that we learn from what happened with cannabis as we move forward. One of the differences is these are individual isolated compounds, whereas cannabis was a range of different compounds where you weren't sure whether one lot of cannabis was the same as another. But here, in terms of legalization or decriminalization, the states do to be following the similar approach to cannabis. And yes, when I was introduced by my colleague, Dr. Noel, I have recently been placed on chair of the Task Force of Responsible Use of Natural Psychedelic Substances by the state of Maryland. Here's a link, and I'm sure we can share this later. This is to ensure safe, accessible, and responsible use of natural psychedelics for the state of Maryland. We have started these meetings, and anyone is welcome to attend due to the Maryland Open Meetings Act. We can make sure you attend these meetings. We need to ensure that all have equitable access to the psychedelics for the range of conditions. So that's what to quickly close up. I've said all this before, is that 2A psychedelics are often stated as 2A, but they do have different psychedelics. We need to work out the non-2As are going to be different. And the direct effects, we also need to balance that along with the longer term effects. This also gets into, if we do want to talk about microdosing, we can talk about that later, because there is still very much to learn. Thank you very much.
Thank you very much, Andy. And I see we have one question from our audience. So, effects of psychedelics binding the TRKB receptor to stimulate BDNF has not been replicated by several groups. Would you like to comment on that?
Yeah, this is actually why I was a little vague with talking about that. And one of the reasons why at the end I did say there is still very much to learn. Yes, absolutely. This is where we really need the solid research here into the psychedelics, because yes, what's been found by some groups has not been replicated by other groups. It's one of the reasons I was a little vague saying that, but at the same time, yes, we certainly need, and this is why we need the research. One of the great things is if we could get these out of Schedule 1 so that it wasn't as hard to obtain them, so that we could actually perform this research. And we need to do this, obviously, with human receptors, because a lot of the work until now has been done with non-human research subjects.
Thank you. Another question. Do you have any comments about this study that indicates psychedelic have privileged access to intracellular AHT2AR receptors?
Oh, I could get into very deep about this, but I think at this point, I really don't want to get into deep on that. That is the science behind here, as I've said, is extremely complicated, and we are still learning much. That is not something I really want to get into here, especially with a primarily clinical audience, except that that is still a very active area of research about whether they do have privileged access or not. It's something I could talk about for hours, but I prefer not to before I go down a rabbit hole. Thank you.
Great. So another question by Jefferson. Feel free to talk. Can you unmute? Jefferson, you may need to unmute yourself to be able to talk. Okay. So
Maybe we could take the question at the end.
yes, let's move the question
Yeah.
to the end. Great. Okay. And with this, I would love to invite Professor Fava. Can you please share your PowerPoint? Enjoy.
Thank you so much, Juana, for the opportunity to talk about, we just discussed how this pharmacology of psychedelics, how they work or might work. But then as, there's a lot of activity in evaluating the efficacy of psychedelics. And there's the question, how do we minimize the risks of having inconclusive or uninformative trials? And from the perspective of drug development, how do we de-risk the trials? And what is the role of placebo? This is my list of lifetime disclosures. Over my 39 years at Mass General, so I work with many companies, but for the past 17 years, all my consulting has been done through Mass General and not individually. So let's start with, how do we de-risk clinical trials? I published a paper where I've tried to summarize how to de-risk, but I'm going to focus on one of the pillars, which is it's critical to employ strategies to minimize placebo response both in phase 2 and phase 3 of the clinical trials. And why is it important? Well, we can classify response to treatment in 3 ways. This is what I call the P minus D plus, the patients who respond to drug but don't respond to placebo. These are highly informative patients that have a specific response to drug but don't respond to placebo. There is another group of patients that respond to neither drug nor placebo, and that's the P minus D minus. These patients are kind of resistant, if you wish, to that treatment and to placebo. And then there is the opposite. There's a group of patients that respond to anything you give them, placebo, drug, they'll respond. They're universal donors. They'll get better in the trial no matter what. Now, when you look at conditions like depression or anxiety, the P plus D plus group, or the kind of typical placebo response, tends to hover around 40%. At the same time, though, the patients who don't respond to drug and don't respond to placebo, they tend to comprise 40 to 50% of the patients. So when you do the math, you can see that only about 10% of the patients are informative. They can actually tell you if something is working, because one group is overly responsive and therefore responds to anything you give them, so you can't discriminate. One group is tougher to treat and so is uninformative for that reason. So the only informative group in a trial with a 40% placebo response and a 50% no response to drug has a group of informative patients that amounts to only 10%, which means that if you randomize 200 patients, only 20 will give you the answer. But if you reduce the placebo response, so you go from 40% to 25%, without necessarily changing the, if you wish, the the group of patients who are resistant, you go from a 10% informative group to 25%. So instead of 1 in 10 patients, it's 1 in 4. That increases dramatically your ability to detect a signal. An example is from a meta-analysis from our group, from Nadia Jovieno and George Papakostas. They conducted a meta-analysis of clinical trials of approved antidepressants. And so these are all drugs that actually have established efficacy, they're approved by the FDA, but they had variable placebo response rates in the trials. And as you can see, when the placebo response rate was greater than 40%, the drug placebo difference was 10% approximately. When it was 30 to 40, it was 15%. And it was 20 to 30, 25%. So what that means is that tell me what placebo response you have, and I'll tell you what the effect size is. Because as you can see, the number needed to treat to go from 10, when the placebo response is greater than 40%, to 4, when the placebo response is 20 to 30. Big difference. So, so one of the issues in psychedelic trials that affects all trials is the fact that there is a widespread use of psychedelics and that these treatments are highly popular, certainly among certain patients. And there is a media emphasis on the efficacy of these treatments. And some articles, refer to them as like, cure for depression or anxiety. So these curative effects increase expectations. And the higher the level of expectations, Luana has published extensively on this, the higher the placebo response. So I'll give you an example. It's another meta-analysis from our group. George Papakostas and I published this meta-analysis of antidepressant trials. And as you can see that when the odds of receiving placebo are 50-50, you have a lower placebo response than when the odds are 33, 25, or 20 or less. So in some ways, the knowledge that there's a greater chance of receiving active treatment modifies expectations, and the placebo response goes up. So the more I'm convinced that I'm most likely to get something active, like 20% or less, the more I will respond to placebo. The moment I have a 50-50 chance, my expectations will be more moderate than I may get the active treatment, and therefore my response to placebo will be lower. So then the question is, how do we manipulate expectations in a psychedelic clinical trial? And one way of doing that is to use what we call a sequential parallel comparison design, or SPCD. This is a clinical trial design that David Schoenfeld and I developed over 20 years ago. And in fact, there used to be a patent for this design that has expired. So the design is in the public domain. And the design leverages one thing of clinical trials, which is in clinical trials that involve placebo, in conditions like depression or anxiety, 70 to 80% of the improvement on placebo takes place in the first half of the trial, regardless of its duration, whether it's 12 weeks, 8 weeks, 6 weeks, 4 weeks. Bulk of the improvement on placebo is in the first half. And so in an SPCD trial, you have 2 stages that are of equal duration. And in the first stage, it's a standard parallel comparison. You compare drug and placebo. The only difference is that you typically have more patients randomized to placebo in the first stage. The ratio could be 3 to 1, 4 to 1. That will lead to generating a large cohort of placebo non-responders that again get re-randomized at the beginning of stage 2. Remember, it's of equal duration. And then they're re-randomized to either stay on placebo or go on drug. And what you do is you compare drug and placebo in stage 1, and you pool those data with the data comparing drug and placebo in stage 2 among placebo non-responders. The placebo responders go on to either stay on placebo or go on drug, but they're not included in the analysis. The patients on drug typically stay on drug, and again, their data are not used for this comparison. So, so what's the effect of that? The first stage compares drug and placebo in a standard way. The differences are expected to be smaller. However, because you're randomizing more patients to placebo than on drug, you have a large cohort of placebo responders. And the second stage is aimed at reducing expectations, because remember, most of the expectations tend to occur earlier on in the trial. That's why 70 to 80% of the improvement is in the first half. So you're reducing expectations because patients don't know, and clinicians, that there are 2 stages. They don't know that there is a re-randomization. So the expectations go down. And you're comparing drug and placebo in a parallel comparison design in placebo responders, where therefore, in some ways, have a history that should predict lower response to placebo. Therefore, since we know the lower the placebo, the greater the drug placebo difference, those differences should be greater. And then the data from the 2 stages are pooled to estimate the drug placebo difference in an averaged way, typically with a 50-50 weight across the 2 stages. And when you use this design, you basically save 30 to 50% of the sample size requirement. So an example, this is a trial, approximately 140 patients, that was conducted in phase 2 by Alkermes, comparing combination of buprenorphine and samidorphan, a mu antagonist, versus placebo in depression. As you can see, there was a nice difference in stage 1 of approximately 4 points. But then in stage 2, the placebo went from 9.6 to 1.8, a huge drop, and the differences go from almost 4 points to almost 7 points. So a huge difference. And when you pool the data from both stages, you get statistical significance. So in the paper that I mentioned from neuropsychopharmacology, we looked at the percent change of placebo in stage 2 compared to stage 1. And the same ratio for active drug. And as you can see, the average on average, in an SPCD trial, the placebo response is 1/3 of the placebo response in stage 1. Huge drop. Now, the drug treatment also loses some efficacy because you no longer have the placebo effect nested within the active treatment, but it doesn't go down. It's only half and not a third of the response. Now, Marta Pessina and colleagues have shown an association between the placebo-activated opioid neural systems and antidepressant response. So what we have postulated was that another way of reducing the placebo is to use pharmacological manipulation. So in theory, it has not been done yet, but I propose to do it. You take drug X and you combine it with a mu receptor antagonist, naltrexone, which, in theory should reduce the placebo response. And you compare that to placebo plus naltrexone. So naltrexone is common to both placebo and active treatment, but is there to mitigate the placebo response. That would be a way of manipulating the placebo, not psychologically with expectations like SPCD, but pharmacologically. The last pillar of the risking trials for CNS is matching the right patient with the right treatment, or what we call precision psychiatry. And what are the wrong or risky patient characteristics for a psychedelic drug trial? One group is patients who don't have the disorder, but it looks like they're having the major depressive disorder or the anxiety disorder, but they're really under stressful circumstances, and they want to participate in a psychedelic trial. Why are they wrong patients? Because adjustment disorders spontaneously improve upon improvement of the situation. So, if I'm having an adjustment disorder because of a stressful life event, and there is a change in that event, I may get better spontaneously, which then will look like a response to whatever the patient is assigned to. Another group that could be the wrong group is drug-seeking behavior, people who want to access a psychedelic treatment for abuse or history of recent substance use disorder, because there you may have exaggerated expectations about what the psychedelics could do, and there could be also non-compliant or non-adherent behavior because of the drug-seeking behavior. Another group, and I think that it's a risk to enroll, is psychedelic drug enthusiasts, because these patients will have the highest level of expectation. They're believers, and their bias may affect the evaluation of the efficacy. Similarly, another group that one would argue could be problematic is treatment-naive patients, because these patients, if they've never been treated pharmacologically, to start with psychedelics for the treatment can be problematic. And finally, of course, prior use of psychedelics. because um, they it may create a significant bias. Well, what do I think are the right patients for a psychedelic clinical trial? Bona fide, ecologically valid major depressive disorder patient, for example, or anxiety disorder patients. History of inadequate response to standard antidepressant therapies in the current episode, or standard anti-anxiety drugs, because it gives you a sense that this is, in fact, not a transient condition, moderate to severe depression or anxiety, comorbid anxiety if it's a depression trial, or comorbid depression if it's an anxiety trial, and adequate duration so that we don't have to speculate the possibility of spontaneous improvement. So if there are good and risky populations, what should we do? How do we ensure that the right diagnosis, the right patients? We can delegate the site investigators and say, you decide. And that's typically the standard. The risk there is the potential bias towards enrollment, and you could use quality assurance provided by vendors or CROs. And there again, if the CROs are aligned with the sites to be biased towards enrollment, then you have a problem. So the third approach is the independent verification or adjudication that the patient is the right patient. Now, why is it important to have the right patients? And I would say the right sites, because there are sites that are very biased in one way or another. This is a paper that Emilio Mello-Peak, Roberto Gomeni, and I published some time ago, using what engineers use to reduce kind of the signal to noise ratio, to enhance, if you wish, the signal to noise ratio, or diminish the noise, which is the bandpass analysis. So in the bandpass analysis applies to the clinical trial, is that you eliminate the sites that have unreasonable placebo response rates. And as you can see, this was in that paper, I think that as you can see, this was analysis of antidepressant paroxetine trials where there was a fair amount of overlap between placebo and paroxetine prior to the bandpass filter. But the moment the placebo responses that were too low or too high were eliminated, there was a much better separation, drug from placebo. And I'm going to tell you a story about Cenerex. Was a company that no longer exists, but I worked with them. They were developing a treatment and a reuptake inhibitor, reversible monoamine oxidase inhibitor, and they conducted a trial, and there was no difference between drug and placebo in their trial. Now, when we went and looked at the placebo response side by side, we found that there were placebo responders that were improbably high placebo response rates. So 26% of the sites had a 40% placebo response. And then there was a group of sites that had an improbable lack of response completely to placebo. And so when we eliminated those implausible signs, as you can see, we went from a trial that showed no difference. There was a clear difference between drug and placebo in the group that came from sites with plausible placebo response rates. Another method to, in some ways, account for the placebo response is to use AI. This is a paper that Roberto Gomeni and I published in Translational Psychiatry, basically taking patients assigned to do 2 active treatments or placebo and comparing the change between screen and baseline prior to randomization in scores and looking at other characteristics and identifying which changes and which characteristics predicted placebo response. And then analyzing with that kind of probability being used as a weight in the mixed effect model. And as you can see, the treatments become significantly effective when you use that model. So in conclusion, it is clear that expectations in psychedelic trials may be excessive. Higher expectations may lead to greater placebo response. And manipulation of expectations with study designs like SPCD may reduce the overall placebo response, enhancing signal detection. On the other hand, pharmacological manipulation with a mu antagonist may also reduce the placebo response and therefore enhance signal detection. And finally, a precision medicine approach where we're finding the right patients for this trial can help. I do want to mention that Juan and I published recently a paper in Nature Mental Health on how to select, or at least, what are the principles to select a control group for psychedelic trials. But my talk today focuses how to de-risk them, how to de-risk those trials. Thank you very much.
Thank you, Maurizio. We have several questions to address. Let's start from the first 2 that have some common aspects. Sergio Marchand asked, using the selected non-placebo responder paradigm, do you still have a good ecological validity percentage of total population response to treatment? That can be combined with the next one by David Smith's. Professor Fava, could you please comment on the generalizability, real-world relevance of the presented enriched design?
These are both David and Serge have these are great questions, that when you conduct a trial, and I'm sure you both are very familiar, you have a heterogeneous group of patients. You have patients that come into a trial that they've never tried anything. You have patients that have tried some things and responded, and some patients that have tried things and never responded. So, so you have a natural heterogeneity, right? Because you have people who may be less likely to respond to placebo, those who have not responded to treatment in the current episode. And you have patients who are more likely to respond to placebo, those who have never tried anything. But you kind of live with that heterogeneity. The SPCD trial basically starts, the SPCD trial starts with a trial that is, takes all comers, but then you add to it a group of patients that are less likely to respond to placebo. So how generalizable that is? Well, as I said, those patients are already entered those trials because they failed to respond to treatments, etc. The difference here is that there's a partial enrichment. My argument is that, let's say that you did a trial where all your patients were enriched in people who had never tried anything, and you had a 70% placebo response. You could never establish the efficacy of anything. So if you take that stance, right, an enrichment. On the other hand, if you took patients who never responded to anything, you would have a 0 because they don't respond to anything, right? So having something in the middle that as a partial enrichment reduces your odds of having all P plus, D plus, it's a way of ensuring that your trial is less likely to fail.
Thank you. So another question, what are the main characteristics that sites with more placebo effects show during a clinical trial, and how to detect them during the trial? So
well, this is a billion-dollar question because that's what many CROs, many sponsors try to figure out. It's complicated because people have, for example, looked at placebo response based on the placebo response of that site in the previous trial, and the correlation is poor. So the same site that performed terribly in trial X may perform decently in trial Y. That said, the one way is to have that adjudication process. In the paper that I published in Neuropsychopharmacology, I discuss it, and maybe I'll put it in. Can I do chat here? I can put a link
in the Q&A, yes.
Of the paper if people want to download it. But the having an adjudication, the reviews, the inclusion criteria, etc. If you have a site that, for example, have 50% of the patients that don't seem to be eligible for the trial, that's not a good sign. Means that there's, there should be a rate of disagreement, but not 50%. So I think it's a good way of determining whether you have a problem.
Wonderful. Thank you very much, Maurizio. There are several other questions. Feel free to start typing the answer, or we will read some aloud after the next talk. And thank you very much, Dr. Finnan, for being with us.
Thank you. All right, let me share my screen here. All right. Am I showing up okay now?
Yes, it's fine.
Fantastic. Okay, thank you so much. I really appreciate the invitation to speak here today, and really some compelling and intriguing concepts introduced thus far, some of which will dovetail a bit with what I'm going to talk about. I'm going to shift the focus of conversation more specifically to the context of chronic pain. And I presented yesterday as part of the NIH Sleep and Pain Workshop. And if you caught that talk, you're going to recognize this slide, introducing the concept of pain self-management. And so I often start with this slide in different types of talks because I think it's fundamental to how we should be thinking mechanistically about mind-body interventions for chronic pain. And I would argue that psychedelic-assisted therapy is one such mind-body intervention. So I think it's fundamental because when we ask patients to report their pain severity or pain interference or other pain-related outcome as the endpoint of a trial, we really need to understand the context in which those ratings are given in that moment. And I think also, what's going to happen to those outcomes after the trial is over. Because we have such a distributed nociceptive system, it can be like a whack-a-mole game trying to knock pain down only to see it crop up again, maybe in the same form, maybe in a different form. But the self-management of these ebbs and flows of pain over time really becomes critical to the patient. And so with our interventions, I think we need to leave patients in a state where they have greater agency to manage those ebbs and flows. We ask them to exercise more. We ask them to become more behavior reactive, to engage socially more often, and so on. But the reality for many patients with chronic pain is that this process of pain self-management is effortful, and sometimes it can be aversive. And so it requires motivation and reinforcement from those pain-related decisions. And there's evidence that the circuits in the brain that govern these behaviors and decisions, the mesocortical limbic system, as one example, are impaired in chronic pain. And there's almost always a cost-benefit analysis that needs to be considered when a patient is engaging in an activity that might yield a delayed benefit, but in the short term might actually increase their pain or increase their stress in some way that's aversive to them. And so our group and others have argued that in order to circumvent those challenges and more effectively self-manage pain, patients may be best served if they have a sense of agency and self-efficacy. And downstream of that, patients need to be able to identify when their pain gets better, when they experience relief, and use those occasions to update their learning models so they can engage in more of those behaviors that bring about pain relief, fewer of the behaviors that promote pain. And so with psychedelic therapy, I'll speak for our group here, we're really interested in seeing if psychedelics can be harnessed to target these processes rather than sort of just expecting that pain and pain severity will kind of magically disappear and stay gone. And so, critical to this effort is engaging and augmenting positive emotions and other positively valent states. So why target positive emotions and maybe more broadly reward processing? I think we can look back to one of the early papers that really made an impact in getting people to think about pain and reward. And in this review from 2008, Siri Leknes and Irene Tracy proposed an opponent process model of pain and pleasure that is, suggests that these sort of common constructs are supported by a common neurobiological architecture that have a wide range of cortical and subcortical brain regions that collectively demonstrate functional roles in the promotion of both pain and pleasure. And then later, David Borsuk and colleagues kind of took it a step further and argued that chronic pain is a fundamentally reward deficient state, but added to that notion basically an idea borrowed from George Koob's work in substance use disorders that anti-reward processes characterized by increased negative affect, stress sensitivity, allostatic load, may augment the problems brought about by reward deficits and increase risk for mood disorders like anhedonic depression, for example, to develop among patients with chronic pain. So in our pursuit of more efficiently and powerfully targeting positive emotions as a means of reducing pain and buffering the negative affective reactivity to pain, we've focused on the classic 5-HT2A psychedelic psilocybin. And so there are now several studies demonstrating preliminary efficacy of psilocybin for major depressive disorder. And I worked on one of them, led by the late Roland Griffiths, which very much shaped the way that we're currently pursuing this work in chronic pain. And in that study, patients with moderate to severe depression were randomized to either an immediate treatment with psilocybin or a delayed waitlist control. And the treatment consisted of 2 sessions, one of which was a moderate dose of 20 milligrams per 70 kilograms of psilocybin, and the second was a 30 milligram per 70 kilogram dose, so a significantly higher dose. And prior to the drug administration sessions, patients engaged in about 8 hours of supportive therapy and other types of engagements with session facilitators, and had really kind of substantial safety oversight from psychiatrists and psychologists. So there's a good amount of engagement, and I think and after the sessions, they then underwent integration. So I'll explain the kind of structure of what I call, the sort of base package of supportive psychedelic assisted psychotherapy in a few slides, but that's essentially what took place here. And so a number of remarkable findings emerged from this trial. I think most notably that depression symptoms profoundly decreased at post-intervention and follow-up. We saw a Cohen's d of over 2, and those effects persisted with really slight degradation out to 1 year. And then in a sub-study of that parent study, which was led by Manoj Das and Fred Barrett, we found that measures of cognitive flexibility and neural flexibility, neural flexibility in this case was assessed with dynamic functional connectivity analyses between the anterior and posterior cingulate cortex, were significantly enhanced by psilocybin in this sample. And so these findings regarding flexibility, I think, are important because if we draw from the positive psychology literature, we know that when one is more flexible, one tends to approach new experiences, be open to engaging in activities that might bring about natural rewards, and be more likely to experience positive reinforcement from them. So we've moved this work into the chronic pain space and are currently conducting an RCT funded by NCCIH to study psilocybin administration for patients with chronic low back pain and comorbid depression. The study is enrolling at Johns Hopkins. I'm co-leading it with my friend and colleague, David Yaden. So this is an active placebo-controlled design in which patients are randomized to receive either a single administration of a fixed dose of 25 milligrams of psilocybin or 40 milligrams of methylphenidate, both of which are administered in the context of what I kind of described earlier as this kind of base package of supportive psychedelic assisted psychotherapy. And in the trial, before and after the dosing session, patients are given 7-day bursts of ecological momentary assessments to track changes in pain and affect as they unfold in the days immediately following the drug session. So we think that that's important because when we're talking about trying to understand the role of expectation on outcomes and how kind of outcomes evolve over time, I think having more data points for outcome assessments is better. So we're going to get a much richer data set, I think, with the EMA here, and we'll be able to see, for example, how symptoms and perceptual and affective changes unfold in the days immediately after the dosing session. So those are kind of some design details of the trial overall. We're actively enrolling, it's blinded, and so I wish I could present to you some data from the trial, but I can't. So what I'm going to do instead is talk about the therapeutic context and then raise some questions about some assumptions that are in our model and maybe some controversies, and hopefully that can be some fodder for discussion. So what is this supportive psychotherapy model? Essentially, it involves a preparation phase, a dosing phase, and an integration phase. And studies to date vary in the exact structure of these phases. In our case, the preparation phase involves 2 separate sessions between the patient and 2 facilitators, 1 lead facilitator and 1 assistant facilitator. Other studies may have more preparation. In our case, we were really kind of attuned to participant burden, and so we kind of wanted to minimize the amount of contact time without compromising safety. And so we think we can do that with 2 preparation sessions that last about 2 hours each. So preparation is where we conduct a life history review, and we ask the patient what they're hoping to get out of the experience. It's an opportunity to listen to the patient's expectations and work with them to ensure that they're not too high, right? Sort of as Dr. Fava was discussing, what we don't want to have happen is either for the expectations to be so high that they're driving placebo effects in everybody and we can't really see a real effect of the active condition, but we also don't want to set people up for an expectation violation where they go in to the dosing session with enormous expectations, and if they don't sort of have an experience that meets those, then they could be really quite disappointed. So we can talk more about that later. In addition to the sort of expectation management and the life history review, we also, in this study, include an explicit component of pain neuroscience education. So we use this as an opportunity to communicate that pain is driven by the brain, and that some of the known neural actions of psilocybin on circuits or circuit dynamics overlap with those that govern the experience of pain. It really is intended to not augment expectations, but to place kind of expectations in a reasonable context. And we take great we make great efforts to communicate to patients that the science of much of this is still very early, and so there's a lot that we don't know. But when it comes to pain, we know that pain is processed in the brain. And when it comes to psilocybin, we know that psilocybin acts on brain targets. And we have a reasonable idea that those targets overlap. And so that provides the patient an opportunity, if they are unclear about why we're doing this study or how effects might work, this is one way in which pain-related benefits could be gained. I think it's important to highlight that other than the explicit component of pain neuroscience education, which we've manualized here and we use to sort of verify that facilitators have addressed it, the rest of the structure and the content of the other components of preparation are largely open-ended and driven by the patient. So this is a supportive, non-directive stance that's very much in the spirit of meet the patient where they are. So this has really been, the most common mode of psychedelic-assisted therapy in the published literature across disorders. But I think it's a very much open question as to whether this is optimal or whether it can be optimized. And I would love to talk more about that, particularly if questions arise. So moving on to the dosing phase. In dosing, we follow a generally standardized protocol that includes the patient lying supine on the couch, wearing a blindfold, listening to music, a standardized music playlist through over-ear headphones. And it's designed primarily to do 2 things. 1, to support the safe administration of psilocybin, and 2, to provide a setting that is conducive to the patient going inward in an open and a curious way, encountering altered states of consciousness if they emerge with curiosity, and if fear emerges, approaching it and then letting it go. That's the general kind of idea. And I know that there are lots of thoughts and opinions as to whether that framework is optimal And there very well may be plenty of other ways to conduct a dosing session, but this is how we are doing it, and I think it is kind of represents the majority of studies that have been conducted so far. After the session, participants are asked to write a narrative of their experience and any insights that they might have gained or may not have gained. And overall, there is substantial interest, I think, in evaluating these various permutations. So, given that we're running a placebo-controlled trial with a placebo medication that creates physiological changes, but typically, is not going to induce hallucinations or alterations of consciousness. I think the question emerges: how do you work with patients' expectations and their perception of expectation violations when alterations of consciousness don't occur? Is it a big letdown early in the session? These are long sessions, remember, 6 to 8 hours that patients are in here. And if a patient in a placebo-controlled trial like this comes in and has the expectation that they're going to get psilocybin, or is sort of actively searching for the hallucination to tip them off that they're in the active condition, that can be, first of all, very distracting. So we don't want patients to be coming in with that type of vigilance, but it could also potentially induce a nocebo effect early in the session. If somebody is like very disappointed early on, the rest of the session may be very negative for them, and it raises the question that whether patient disappointment could ultimately influence their outcome reporting down the line. So these are questions that I raise. I don't have answers. I can talk about sort of some of the things that we do to try to manage those expectations, if that's of interest later on. But after dosing, we're doing 3 integration sessions, which are largely patient-centered, again, non-directive and supportive. They operate both as occasions for safety check-ins and opportunities for patients to unpack insights that they might have gained, how that might motivate behavioral or cognitive, affective, or social changes in their daily lives. And in many cases, this process happens in a nonlinear fashion. So sometimes patients are massively changed right away. Other times, it can evolve from initial disappointment or maybe a lack of clarity in the day of or the day following a dosing session to, very clear insights and positive changes that emerge days or sometimes weeks later. Sometimes nothing changes at all. So again, lots of opportunities here, I think, to expand on this basic supportive framework in order to try to optimize the reliability of effects, the magnitude of effects, and I think specifically the duration of effects. Taken together, our model for how psilocybin may affect change in patients with chronic low back pain and comorbid depression is via affective mechanisms. So our preliminary data, suggest that we can expect to see big increases in positive affect, big decreases in negative affect in the week and month after drug administration. We will see if those effects emerge here, but the preliminary data sort of certainly trend in that direction. I think less certain, but a hypothesis that we're following up on here is whether changes in affect can modulate pain. So we're, in our case, including an experimental assessment of music-based affective pain modulation and seeing if that changes over time for patients in the active versus the control condition. So these are the proximal outcomes, but our overarching hypothesis is that changes in these mechanisms will ultimately drive a clinically meaningful reduction in low back pain. So there are a number of assumptions to this theoretical model. First, we're assuming that psilocybin is going to drive these effects. and that the psychotherapy, that a supportive non-directive psychotherapy is there to kind of accompany the and provide a safe context for the psilocybin to do its work. So that's definitely an assumption, and I think one could approach this trial or a trial like it with a very different assumption, that psilocybin, for example, should really be there to enhance some other psychotherapeutic intervention. We're also assuming that affective changes are going to emerge largely through insights gained, and that will be sort of supported and reflected through integration. Is that necessary? Is the integration period necessary? I think most folks think that's the case, but it is an assumption of this model. And it's a question, I think, of to what extent does integration primarily serve as a sort of check on, safety after the fact versus really driving effects. And we're also, assuming in this case that these downstream pain reductions are going to happen via psychological mechanisms, right? So, the primary targets for us are affective, but we're also assessing secondarily psychological flexibility, openness to experience, hedonic capacity, a number of these factors which are related to positive affect, for example, that may play a contributing role. How can we optimize this basic framework? I think, a number of things to consider. The theoretical orientation of the psychotherapy that accompanies a psychedelic drug administration is really important. We're basically taking an agnostic stance with this non-directive supportive framework. A lot more could be done. One could choose, for example, a direct intervention like acceptance and commitment therapy or mindfulness to accompany this type of intervention. And there are a few models that you could consider. I think one would be that you deliver an entire psychotherapeutic intervention first, and then a psychedelic assisted therapy after that. For example, Ben Lewis has done similar work to that with an MBSR and psilocybin study, where an entire course of MBSR was given prior to undergoing preparation, dosing, and integration. Another consideration would be to weave a psychotherapeutic intervention into the fabric of a psychedelic assisted therapy. And this might be more efficient. You can reduce the number of sessions, and you kind of color the three phases of psychedelic assisted therapy with the psychotherapeutic modality of choice. I think there are some controversies to consider here, and then I will wrap up. One is this kind of semantic, I think it's more than semantic, question of, is it a psychedelic assisted therapy or psychotherapy assisted psychedelic administration? These are potentially two different things, and they are being trialed. I think both of these options are being trialed. They're, I think, commonly both referred to as psychedelic assisted therapy, but they could, operate very differently. The process for managing patient expectations, I think, is very much, not clear, not well operationalized. And I think we would do well to develop some standard protocols for managing expectations in the preparation phase, particularly when there's a placebo control. We want to kind of mitigate the potential for violations to occur. And then finally, I want to touch on something that Dr. Fava brought up. This question of excluding patients with prior recreational psychedelic experience. We're doing it, and that is the common, I think, model. But I'm not so sure of whether that is totally necessary in every type of psychedelic trial. I think when I think of what we're doing with psychedelic assisted therapy, that is the intervention. If somebody has had prior recreational use, as long as it wasn't, like a couple days ago or, within some reasonable time period, I'm not so sure if that should automatically exclude them from participating. I think that's different than certainly like a psychedelic enthusiast who may have very high expectations, maybe using lots of psychedelics. But I think it's worth sort of considering whether a blanket exclusion of people with prior recreational experiences is necessary. And as a comparison, when we enroll people in trials of CBT, for example, we don't exclude them based off of, if they're used to talking about their emotions with friends and loved ones, which is something that is going to happen in that trial. Maybe if they had a CBT experience in the last year, they should be excluded, but the elements of that experience shouldn't necessarily be exclusionary. So these are just some thoughts that I've had and might stir up some controversies. And with that, I'll end and say thank you to my colleagues, my postdoctoral fellows, my current fellow, Nick Cherub, and plenty of other prior fellows and coordinators who've helped make this work happen, and of course the funding that we've gotten from NIH. So thank you.
Very good. I would invite all the speakers to come on board. In the meanwhile, there are some questions. Feel free, Patrick, to answer some, and some you can answer by typing. I read one by Boris. Thank you, Dr. Finnan. Have you found that efforts of maintaining the blind has gotten in the way of engaging with chronic low back pain patients?
Have we found that what is good at maintaining the blind? Sorry.
These efforts to maintain the blinding somehow can be challenged, ethically speaking, in terms of engaging with the patient.
Yeah, yes. I think, the approach that we take is to, when we're preparing patients for this trial, we try to communicate to them that that the experiences that they think should come about with with psilocybin may indeed come about, but they may not, even if they're in the active condition, right? So there's plenty of examples in our previous trials and other trials where people who are randomized to an active high dose of psilocybin ultimately do not experience alterations in consciousness. And so I think communicating that that is a possibility, along with the fact that they could be randomized to the placebo condition, and also that in many trials, including psychedelic trials, patients who have been randomized to placebo conditions believe that they may have gotten the active drug, and that they indeed report alterations of consciousness. And so kind of setting that equitable framework for what each condition could bring about is one of the ways that we try to manage expectations and preserve the blind, so that they, we know that this kind of functional unblinding is really a problem, but that's the approach that we've taken to try to minimize that.
Let's push this further with Shen's question about the pain neuroscience education. So some people may implicitly believe that psychedelics work via supernatural channels. For these people, their expectation may be inadvertently manipulated. Any thoughts in terms of ethical consideration and clinical consideration?
That's a great point. And I guess what I would say to that is that we do not sort of guarantee or even say that this is how these effects are going to happen. We present the pain neuroscience education as really a way to level the playing field for patients coming into the trial who may have an understanding about pain that is that would suggest that pain is entirely peripherally mediated. And we know that lots of people kind of have that sort of belief about pain. And we want kind of everybody to come into the trial with a similar kind of understanding of what pain is and how it operates in the brain, and provide one potential avenue through which psilocybin could work. But we present it as that. We don't say this is the avenue through which psilocybin will have its effect if it works for you. So, again, we're careful to not be overly prescriptive or very prescriptive at all when we prepare patients for these trials.
Great. A question for Dr. Finan, but also everyone. Do you see any difference between females and males patients when we talk about response to psychedelics?
That's a good question. We have not been able to analyze our data yet, so I can't speak to that in our trial.
Maurizio, any thoughts, sex differences?
Any thoughts about the differences in what?
In the response to psychedelics between men and women?
We don't know enough.
We don't know enough. Okay, some other questions very quickly, again from Boris. What are your thoughts on pairing psilocybin with physical therapy rather than driving the trip inwards? Well,
Really good question. My, our postdoc, Nick Cherub, is really interested in this and is kind of asking these questions as well. I'm not aware of that having been conducted as a therapeutic framework yet, but I think that I think these types of sort of functional goals are really important. Whether if Dr. Heifetz is suggesting doing physical therapy during the dosing session, that's kind of another question. I hadn't really been thinking about that, but I'd be curious if that was the idea. That strikes me as really complex, and but in general, I think incorporating physical therapy as a framework and an endpoint, sort of gains in physical therapy as an endpoint of psychedelic trials is really an interesting and important direction.
great, and it's 4 o'clock. So with that, we can conclude, and I would invite Jason to come on board this webinar. It has been terrific. Thank you to Andy, Maurizio, and Patrick for your contribution. And we look forward to learn more about your results and your research on psychedelics in depression, policies, ethics, and pain.
And the advocacy.
And the efficacy. That is why we are here at the PBO Center. Continue to follow us. We will have 3 more webinars in spring, so you can register, be member of the PBO Center, and continue to participate to our lecture. Thank you all.
Fantastic.
Thank you.